Hi, I am Atya and I am one of the IMT ones and today we are going to discuss pleural effusion. Um, so we will go through the causes of pleural effusion, the investigations which are required in a case of pleural effusion and the management options and also a little bit about chest range and some complications associated with it. So we will start our presentation with a case scenario. So it was an 85 years old lady who had been having right-sided pleuritic chest pain since 2 days, and she had been treated for a pneumonia 1 week back, and she had past medical history of rheumatoid arthritis. She also had atrial fibrillation, and she also had a chemotherapy for breast cancer previously. She was on certain medications like apixaban, methotrexate, and bisoprolol. Uh, on doing her investigations, we found that her neutrophilia and CRP was resolving. However, on the X-ray she had a tiny pleural effusion in addition to the right lower lobe consolidation which has been resolving. So, in this patient, what causes of pleural effusion would you like to rule out in the history?
Cancer, infection, pneumonia.
Yes, so in this patient there are multiple causes, like firstly she had pneumonia and it can be related to the uh, um, infection, the lung infection she had causing a parapneumonic effusion. Then she also had a history of connective tissue disease, this rheumatoid arthritis, which uh, which can lead to pleural effusion if she was having flare up. So it is important to ask about fever, weight loss. Um, it is important to ask about joint pains and rashes, and also the history of breast cancer. It is important to ask about the fever, weight loss, and night sweats to rule out any reoccurrence. And then because there is an atrial fibrillation history, it is important to rule out transudative causes like heart failure, which might be causing the pleural effusion. So the causes of pleural effusion, they can be divided into transudative causes and exudative causes. Like we discussed, in terms of exudative causes in pneumonia, autoimmune disease, malignancy, and also pulmonary embolism, which can present as sudden shortness of breath, must be ruled out. And then in terms of transudative causes, we discussed about heart failure, and the other things that are important to rule out include uh, renal and hepatic failure, which can lead to low albumin and then cause effusion. And it is important to ask whether there is any sort of peripheral edema, ascites, abdominal distension in the history, and also in terms of uh, um, low protein, it can occur due to diarrhea and malabsorption. Other than that, not in this patient, but it is also important to rule out any, if the patient is presenting with falls, to rule out any traumatic causes of the pleural effusion. For example, the patient might have had a procedure done, or they might have had a fall which can lead to hydrothorax or a chylothorax. So, any suggestions on what we are looking for in examination in terms of respiratory signs and general signs?
Reduced respiratory sounds, tap, uh,
So,
X-ray.
yes, so we are looking in terms of respiratory signs. What we will find is that there are reduced breath sounds, um, and on the side of the pleural effusion. Then on percussion, there will be a stony dull percussion note, and the vocal parameters would be reduced. In addition, there would be there can be a tracheal deviation if the pleural effusion is quite large. And in terms of general signs, what we are looking for is that there might be a malignancy. So to rule out that, we need to look for any lymphadenopathy, any clubbing, and uh, in terms of transitive causes, looking for any peripheral edema, raised JVP, and in terms of the rheumatological causes, look for any joint pains, rashes, and any spider nevi, which might be related to the liver cirrhosis. So for the patient that we discussed, um, um, we thought that the effusion was directly related to the pneumonia she has had previously, because there were no any red flag signs. So what we did was we scheduled her for a repeat X-ray in 4 weeks, gave her another course of antibiotics, uh, and also some analgesia to make sure that her pain had settled. She was also safety netted for discharge, so that, like, if she develops worsening shortness of breath, any chest pains, that she can come back into the emergency department. So that was the case in if a patient has very small pleural effusion. In if a patient comes in with an X-ray looking like this, so in this case there is a very large pleural effusion. Any suggestions on what investigations would we like to do for very large pleural effusions? So we will be doing a full blood count and baseline urea and electrolytes and liver function tests to identify the cause, and also a coagulation screen to see if the patient has got a high INR. Um, then also we do an X-ray and an ultrasound uh, to further characterize the effusion, and also to find out the cause. We might have to do a CT scan, and finally we will do a pleural tap to further identify what is the type of pleural effusion. And then in certain cases we might have to do investigations like bronchoscopy, biopsy, and echo CT tap to look for the cause of the pleural effusion. So the X-ray findings, anyone can describe what we see in this X-ray? So in this X-ray we are seeing that there is a cardiac pacemaker, then there are some cabbage wires that we can see, and then there is a small pleural effusion that we can see on the X-ray, and it appears as uh, a small line um, near the costodiaphragmatic surface, and this is called the meniscal sign, which is characteristic of pleural effusion. However, in certain cases, we can there can be a pleural effusion, and there is it can present in other forms. For example, in this case, it presents as a raised right hemidiaphragm. What is happening here is that the pleural effusion has collected above the diaphragmatic surface, and it is called subpulmonic pleural effusion, and it presents as a raised right hemidiaphragm. In certain ITU patients, what happens is if the patients are lying flat, um, the pleural effusion can trace down um, along the costal surface, and this can present as pleural effusion along the coastal margins and not specifically in the angle. Um, Also, if the patient is lying flat and the pleural effusion is quite large, it can present as a generalized haziness of the lung. Um so there are different ways in which the pleural effusion can present depending on the position of the patient, especially in ITU patients. So once we have an X-ray, we usually do an ultrasound if we are considering to tap the pleural effusion. Firstly, because the X-ray shows only the pleural effusion if it is greater than 200 mL, while the ultrasound it can detect lesser volumes of pleural effusion. Other than that, what we are looking for in an ultrasound is whether the lung it is uh, that tethered to the pleural effusion, whether there are any septations, and also we can measure the volume of the pleural effusion. um, for example, if there is a pleural effusion, um, if there is a pleural effusion, then we can measure the distance from the diaphragmatic surface, and then uh, we can multiply it by 20 and calculate the volume in ml. So yeah, this one. And then in the ultrasound, if we are doing if we are wanting to identify the pleural effusion, there are three signs that we need to be aware of. Firstly, in a normal ultrasound, what happens is that the liver is reflected into the normal lung tissue and it appears as a uh, mirror artifact along the diaphragm, and this is the normal uh, person. And in cases of pleural effusion, the liver is not reflected into the lung tissue, and then there is a dark area that appears, uh, which is the pleural effusion. So the absence of the mirror artifact is diagnostic of pleural effusion. Then the other thing is that usually in the lung tissue, what happens is that the spine uh, it's not visible uh, in the area above the diaphragm, because the normal lung tissue it does not allow reflect the reflect the sound waves along the spine. And however, in cases of pleural effusion, when there is fluid, the spine becomes visible above the diaphragm, and this is also a sign that their patient has got pleural effusion. And lastly, what we are looking for in the ultrasound is that when a patient takes a deep breath in, it causes darkening of the screen of the ultrasound, and this is called the curtain sign. However, in case of pleural effusion, the lung is we see a collapsed lung and surrounding pleural effusion, and so the curtain sign is absent in cases of pleural effusion.
Uh-huh.
Now, in terms of CT scan, sometimes we might want to do a CT scan in for pleural effusion. So what happens is that uh, um, in certain cases we are able to identify the septations, and the pleural effusion might be very small. So and in those cases we might need a CT scan to further identify the location of the pleural effusion and to identify the cause, and also it can also help us to determine whether the effusion is transudative or exudative and whether any changes in the lungs are visible. So
Uh-huh.
for a CT scan, we can identify the transudative and exudative causes by looking at the CT scan, like in here, this in transudative causes, the pleural effusion, it collects in the dependable region following the gravity. However, in terms of exudative effusion, it can present as like a loculated uh, effusion along the lung. Secondly, the thing we are looking for is this black shadows, which are indicative of gas forming bacteria, which lead to small pockets of air in the pleural effusion. And the third thing we are looking for is this split pleura sign, which shows as the bright white line along the CT scan, while in terms of transudative ascites there is no bright line. This occurs because the pleura is inflamed in exudative effusions and it appears bright. So for the hemothorax, we are looking for the density of the effusion. If the intensity is similar to the muscles or even greater than that, or if there are spots of high intensity showing clotted blood, then we are thinking that the effusion might be actually a hemothorax. So in terms of investigations, once we have found a pleural effusions, we usually do a pleural tap. Any suggestions on how many bottles we collect for the pleural tap, and how many, if there are any other containers that we use? So for the pleural tap, we usually collect it in 3 bottles, and the we also collect the effusion in a syringe, which is the blood gas syringe, and it is to look for any pH changes, which are important to determine whether the effusion is exudative and whether the patient needs a drain. Then the 3 bottles we are sending it for biochemistry and cell count and cytology, and also for culture and sensitivity. Other tests we might be doing depending on what we are suspecting are amylase, ADA levels, triglycerides, R factor, and there are plenty of other tests. And any suggestions on the absolute contraindications of a pleural tap? So the pleural tap, it is contraindicated in if there is like infection overlying the lung tissue, and then if there is the patient is non-compliant, or thirdly if there is no access, like if the pleural effusion is very small, then it is contraindicated. There are other relative contraindications. For example, if the patient is mechanically ventilated, it is a little bit difficult and a risky procedure. And also if the patient is coagulated, like if they have coagulopathy, the INR is raised, in that case we need to determine whether the risks outweigh the benefits. However, it is not an absolute contraindication. So the pleural tap results, what we are looking for, whether is the pleural effusion exudative or transudative, and we use the Lights criteria. And what is the Lights criteria? So the Lights criteria is that the pleural effusion protein, it should be when we divide it by the blood protein, it is greater than 0.5, and similarly the LDH in the pleural fluid, it is when we divide it by the blood serum LDH, we find that the if the ratio is greater than 0.6, so that shows that the effusion is transudative. However, another thing to be aware of is that if the value comes around just around 0.5 or 0.6, then in those cases it might be that the patient might have a transudative pleural effusion. And what happens is, when we give them diuretics, it can concentrate the protein in the effusion, and it can present as a like borderline exudative picture, and it's important to consider the clinical context, and we call these effusions as pseudo-exudative, which are actually transudative effusions, which have had like concentrated proteins in the fluid. So just a run through on different conditions and what the pleural fluid feature we are looking for. In malignancy, we are looking for a positive cytology. For tuberculosis, we usually uh, send the fluid for ADA levels or cultures. However, these are not very sensitive, and the cultures are not very sensitive, and the ADA levels are not very specific. And in terms of rheumatoid arthritis, we send it for rheumatoid factor and raised LDH and cholesterol. If we are suspecting pancreatitis or esophageal ruptures, important to do amylase. And in terms of cardiothorax, important to do triglyceride levels. So, how do we manage transudative effusions and exudative effusions? So for the transudative effusions, we usually manage them um, by by treating the underlying cause. For example, if the patient is having a heart failure, we will optimize their medications. If they are having uh, renal failure or liver failure, we will treat that and put the patient on fluid restriction. Having said that, there are certain patients who might be having symptomatic breathlessness with the effusion. In those cases, we might need to do therapeutic drain or um, therapeutic pleural tap or drain to relieve the symptoms. Then, in terms of exudative effusion, if we are considering that the patient is having an infection, we might consider chest drains with fibrinolytics. If we are considering the patient is having malignancy, then we will be doing we can do a chest drain to relieve the pleural effusion, and then followed by pleurodesis or an intrapleural catheter. However, in certain cases, if this is not helping with the pleural effusion, then we might need a cardiothoracic referral for pleurectomy or decortication. Um, um, and the chest drains. What are the indications to put a chest drain in a patient? So, for the chest drain, we usually put it if the pH is less than 7.2. If we think that if we tap the pleural effusion, we find out it is purulent, or if there are organisms growing in it. Those are the three main indications. However, in cases of malignant pleural effusions, we might do a chest drain, and in cases of large hemothorax, usually done by the surgical team, we can do a chest drain. And also for the patients with respiratory compromise, we can do a chest drain to relieve the symptoms. However, the chest drains are usually done in hours, because there are complications associated with the chest drain. Uh, so just moving towards the end, there are three types of chest drains that we usually use. The first one that we use more commonly is this one, that is having a collection chamber. It has an underwater seal chamber, and then there is an air leak monitor in which there is bubbling if there is any air leak in the system, and then there is a area where we can apply the suction for the chest drain. So this is the normally used chest drain. However, the chest collection chamber system. And the other one is that topaz drain, which is a digital drain, and it is used to determine how much, like exactly how much air or fluid is being drained. And it is usually used when we are at the end of the drainage. We want to calculate if there is any further fluid being drained, and also to apply suction if needed, so that we can control the suction more accurately. Then there is this drain which is quite lightweight, used at the end of intrapleural catheters, and it is changed like every alternate day by the district nurses, and it is used in patients who are having a malignancy and they have a long term drain inserted. So regarding the complications, just two complications of the chest drains we will be discussing. The misplaced chest drains. How does a misplaced chest drain show up on an X-ray? So we usually are looking for a fenestration, like in this chest X-ray there is a fenestration in the chest tube, and all the fenestrations of the chest tube should be inside the thoracic cavity. If we see any chest tube in the fenestration outside the chest cavity intersubcutaneous tissue, it can indicate a misplaced chest drain. And how to manage that is that we need to remove the chest drain and apply a three-way bandage, which is like taped on three sides, not on four sides. The fourth side is left open to allow the air to escape but not to enter into the patient. Then the other thing that we are looking for in complications of chest drain is tidling. Sometimes the patient's drain stops swinging, and there it can be because of the chest drain is kinked or obstructed. However, there it may be that the patient's lung has fully re-expanded. And the third reason why tidling might stop is an air leak. For example, if there is a bronchopleural fistula, or if the air is leaking into the system at the site of drain insertion or anywhere along the tubing, that can cause an air leak, and it can present as the stoppage of like swinging, and there is also bubbling in the air leak chamber in those cases. So just the take home messages for the teaching are that we can manage small uncomplicated effusions conservatively, and if they are not tappable, they are not tappable. And then if the ultrasound is like we can use the ultrasound to further characterize the effusion. And the uh, pleural tap, it is sent for pH, microbiology, cytology and biochemistry. um, and also we can differentiate the effusions translative and exudative by using the lights criteria. Thank you.